on some Decadron, right?
Mm-hmm.
Do you feel any differently on the Decadron than not on the Decadron?
Haven't I been on Decadron forever?
Well, you weaned back, and then you ended up in the emergency room, and then you're at 2 and 1 right now.
Yeah. Mm-hmm. No, that seems to be a pretty good balance.
Okay.
The steroid rise, and my appetite's under control, and of course I don't know what my swelling looks like, but.
Right. So, let's crank this up here.
Yeah, I like the strength of Decadron now. Or go down, or get weaker.
So the array.
So that's by date.
That's that. June and April, right. Okay, so we want this one and this one. The bottom row is June 27th. The top row is going to be April the 23rd. Right.
April.
April on the top row,
2 months.
June on the bottom, 2 month interval there between scans. Let me just link them up.
And then is this the exact same slice through my brain, this one and this one?
Yeah, that's what I'm doing now. Yeah, so I
Okay.
get it in the same spot. There we go. There. All right. So what Sonia saw last week, and she reviewed this with Dr. Ulmer, one of the radiologists, is in the right temporal lobe of the brain, the amount of swelling is more than it was before, looking at these two scans here. As we go up, it's not much different there, or there, or there, or there. But once we get to here, higher up over the frontal parietal lobe of the brain, clearly the front edge of the swelling is in front of where it was before. Here, the front edge of the swelling didn't come to the front of the ventricles. Here, the front edge of the swelling is in front of the ventricles. And it's broader behind. There's more swelling on that side of the brain.
Mm-hmm.
Because the size of the head is the same, but the size of the white area.
What's the dates again? Where are we talking
April 23rd on the top.
Okay, 4/23.
June 27th on the
Okay.
bottom. Right. All the way up to the top.
Mm-hmm.
So that's going to make your thinking slower. It's going to make you weaker on the left side. It's going to make you not as aware of your left side, headache, all that kind of stuff.
Mm-hmm.
So swelling is just a sign on a MRI scan, a smoking gun, that something's causing it. So the question is, what's causing it? And you recall that your tumor sort of has two components. There's this component here, which hasn't changed really much in size at all, but there was this other bit here, this little thing here, which is bigger now. That's what Dr. Ulmer was reacting to. That you hardly see it there at all, and you see it here.
Mm-hmm.
So the question was, what is that here? 3 months and change from the end of your radiation. Is it progression of tumor despite treatment, or is it what we call pseudo-progression, a really robust inflammatory reaction to it? And that's why the MRS was done. And I can actually give you this to take home. And it's actually, we do the MRS in two different ways. It's this one, which is the most important one. This is called short echo, that's called long echo.
Okay.
And it's I'm just going to put a line through this, because this is the one that you want to pay attention to. Okay. So what you see here is two things. This is the choline piece. So what they've done is they have looked at that area of the brain with the MRS. And this is a chemical signature. So the choline peak is higher than the NAA peak. That is what you see in a tumor.
Wait, what is, say it again?
The choline peak here is higher than the NAA peak here. The choline peak is up here, and the NA peak is down there.
Which is indicative that it's tumor.
Tumor, because what happens in a tumor is choline is in the wall of the tumor cell. And so when tumor is multiplying, choline is turning over, and you get a high peak. And because the tumor invades the brain and it can destroy the normal brain cells, the NAA comes down. In a normal brain, this ratio is just the reverse. The choline is low and the NAA is high. But in tumor, the choline is high and the NAA is low. And what happens is, as tumor cells die, they make this CH2 and the CH3, which is lipid and lactate. So this is the picture of a necrotic neoplastic process. So that the center of the tumor is dead. That's this black area, okay? But it's tumor. And it's strong. This profile is strongly suggestive of a GBM. And you remember the original tumor had a little bit of oligodendroglioma in it, and not really much oligodendroglioma in it. So you can keep this because I just printed it right off the screen. So that being the case, I would, if we saw this picture 1 month from the radiation, 2 months from the radiation, I would say, let's stick with the temodar, because this tumor is promoter methylated. The MGMT was promoter methylated. But we're more than 3 months out now, and it's not just this area that I'm concerned about. It's really not changing. I'm concerned about this. This is changing. And remember, it's glioblastoma multiforme. This is the part of the tumor that was removed. This is where the MGMT sampling was done. It is possible that this part of the tumor is methylated and responding to temodar, but this is what's going to get there. This part is not. Yeah, right. And there was a study done by a group in Italy about 2 years ago now, where they did a biopsy of the tumor at the diagnosis, and then when the tumor came back, and they did an operation again, they biopsied the tumor again. And sometimes it was methylated initially and methylated again. Sometimes unmethylated, then methylated. Sometimes methylated, then unmethylated. And sometimes it stayed unmethylated. It could go any which way. Because within that tumor area, you have different clones of cells, and they're behaving different ways. I think it makes sense at this stage of the game to stop the temodar and switch you over to Avastin. Okay? One might ask the logical question, should we keep the temodar going and add Avastin? I don't know that answer yet, because the study that was done using the two of them together up front, the study has been completed, all the patients are in the study, but they're following them for results. And we should know the results at the end of this year, because there will be enough follow-up and enough patients. And if it turns out that the combination is better than temodar alone, we could add back the temodar. But I don't think until we know the results of the study, we should be giving you 2 drugs simultaneously outside of the study. Right? Because 2 drugs simultaneously is exposing you to side effects of 2 drugs itself. One might say, Dr. Malkin, let's suppose when you switch to Avastin, that this one gets better and the original one doesn't change. I'd consider adding the temodar back at that point.
In August.
Yeah.
You should see a change by the August.
Yeah. So when you have a patient on Avastin, and I think you would be a good Avastin candidate because this is your blood volume study here, this is tough for someone who doesn't see these all the time. The whole thing looks turquoise, right? But this rim here of blood flow, where the radiologist puts the little white arrows, that's thicker than it was back then.
And that's the original tumor.
And that's the original tumor, right? So there's lots of blood flow still going into this thing. And this area back here
starting to thicken up, this green blood flow. It was kind of turquoise before and a little thinner. This is starting to thicken up. The more,
It's just getting more blood.
so it's getting more blood flow.
Encouraging this tumor to grow here.
Yeah, right,
Okay.
right. More so than the original tumor there. So I'm thinking, so there's lots of blood flow in here.
That's a target for Avastin. Avastin is designed to cut off the blood supply to a tumor. When you get a good response to Avastin, you typically see it after 6 weeks and certainly after 12 weeks. After one cycle and certainly after 2.
If it's going to be effective.
If it's going to be effective. You typically see the result early. The patient may notice the effect before we get the next scan. The literature has shown responses in 2 weeks, 3 weeks. And the patient may say, oh, I'm feeling so much better, can we get off this Decadron? That's the effect they notice, even before we get the next scan. So I think it's reasonable to switch you over to Avastin. We do a scan in 6 weeks. We see how things look. And if we're getting a great response to Avastin, I think we continue with Avastin by itself. If part of it is really responding to Avastin, and the other part not as much, I might add the temodar back. Because I know that this, at least, was promoter methylated. So we have options. And we keep this thing going. Because the company's study is now combining this with Avastin.
Okay.
As well too.
Right.
Okay.
Right. I know you're not on the study, but I know Dr. I'm just blocking on his name. Engelhardt. Right. You know, feels that it's reasonable for you to continue on this. I got no objection.
Can you refresh my memory? Is the second area, is that operable down the road?
No. It's not. You don't. This is called the corpus callosum. You don't want to be going in there. It will mess up your memory really bad. Because this part of the brain transfers nonverbal, visual, sort of where I am in space orientation from the right brain to the left, so you can verbalize it. And it moves verbal information from the left side of the brain to the right, so you can move the left side of your body. The left brain tells the right brain how to move the left side of the body. You go in there and try to operate, and you could really mess you up. You don't want to do that.
Okay, so it's disappointing that temodar is not working, and
Yeah.
this new one is.
Yes.
Yeah, because I know you mentioned if we go to Avastin, that's indicated.